وإذا مسه الشر كان يئوسا قل كل يعمل على شاكلته فربكم أعلم بمن هو أهدى سبيلا صدق الله العظيم. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Ladies and gentlemen, the third agenda is opening remarks of Dean Medical Faculty, which is represented by the Secretary of Program Studi Pendidikan Dokter for Dr. Anung Putri Ilahika, MSI. You might take the floor.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahirabbil alamin. Assalatu wassalamu ala asrofil anbiya'i wal mursalin wa ala alihi washabihi ajmain, amma ba'du. Yang sama-sama kami hormati Bapak Dekan Fakultas Kedokteran Universitas Muhammadiyah Malang, Dr. Medis Setiawan, spesialis penyakit dalam Vinasim. Ibu Wakil Dekan 1, Dr. Ruby Riana Asparini, spesialis bedah plastik rekonstruksi estetik konsultan. Ibu Wakil Dekan 2, Dr. Sri Adila Nurainiwati, spesialis dermatovenerologi estetik. Bapak Wakil Dekan 3, Dr. Indra Setiawan, spesialis THT bedah kepala leher, subspesialis rinologi. Ibu Kepala Program Studi Pendidikan Dokter, Dr. Fathiah Safitri, Magister Kesehatan, yang mohon maaf beliau semuanya belum bisa hadir di tengah-tengah teman-teman mahasiswa semuanya dikarenakan ada beberapa agenda yang harus beliau semua hadiri. Terima kasih juga kami sampaikan kepada speaker kita, Mam Gelin Manalang, dan juga moderator kita pada pagi hari ini, Dr. Gita Sekar Prihanti, MP Deket, juga kepada panitia yang sudah menyelenggarakan kegiatan kuliah perdana mahasiswa baru angkatan tahun 2025. Alhamdulillah, teman-teman bisa dihadirkan di auditorium GKB 5 yang insya Allah nanti juga akan menjadi tempat kuliah teman-teman semuanya, sehingga itu bisa dijadikan motivasi ya. Dan alhamdulillah kuliah perdana kali ini diisi oleh narasumber yang bukan main ya. Beliau sangat luar biasa dan beliau sudah di sini sejak hari Selasa. Ya, sudah hadir di tengah-tengah kita dan saya harap teman-teman mahasiswa semuanya yang masih itu sudah tampak ya beberapa orang yang ingin saya bangunkan. Sudah tampak dari sini, coba dibangunkan, dilihat teman yang kanan kiri. Nah, begitu ya. Mohon dengan sangat diperhatikan dan semoga banyak hal yang bisa teman-teman ambil sebagai salah satu motivasi dan stimulus ya untuk kedepannya. Kami mohon maaf atas semua yang mungkin kurang berkenan dalam kegiatan ini. Saya juga menyampaikan salam dari Bapak Ibu pimpinan. Ini menjadi pertama ya teman-teman ya, kemudian nanti akan ada beberapa kegiatan lagi dan saya harap tidak ada keluh kesah. Ya, sudah senang berada di auditorium? Oh iya. Ya, tetap dipantau temannya kanan kiri, kalau ada yang terlelap sebentar dibangunkan ya Dek. Ya, saya rasa itu yang bisa saya sampaikan. Matur nuwun juga kepada Dokter Rubayat yang sudah mendampingi Mom Gelin, luar biasa, matur nuwun. Nggih, saya rasa itu yang bisa saya sampaikan. Semoga acara ini berjalan dengan lancar hingga akhir acara nanti. Kurang lebihnya saya mohon maaf. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. For Dr. Anung, please remain at the stage. Maybe in front of the stage. We will invite the moderator and the speaker today, Dr. Gita and Miss Kaylin, for the photo session. And the lecturer, maybe Dr. Rubayat, Dr. Mariam, and Dr. Nimim, Dr. Irma. For students, adik-adik mahasiswa dimohon untuk berdiri di tempatnya masing-masing. Ya, you may take the photo. Kita hitung. Kita hitung ya, adik-adik, Miss. 1, 2. On the right side. 1, 2, 3. International style. 1, 2, 3. Mohon maaf, Miss, excuse me, you will meet the photo session again from on the other view. Oh, silakan adik-adik duduk kembali. Terima kasih, thank you. Thank you, Miss Galen, thank you, Dr. Rubaya, Dr. Irma. Ya, okay. For all the students, we are going to the core agenda, the agenda inti. Today we have Mrs. Galen Manalang, Junior PTRP, Magister of Occupational Health from University of Philippines, Manila. Ma'am Galen will teach us about the overview of occupational health for the medical student. The session will be led by the moderator. Please welcome Dr. Gita Sekar Prihanti, MPDK. I will read the curriculum vitae first for Dr. Gita. Dr. Gita saat ini sedang menjabat sebagai Kepala Medical Education Unit untuk Fakultas Kedokteran Universitas Muhammadiyah Malang. Berikut adalah kurikulum vitae beliau. Beliau sangat berpengalaman dalam bidang organisasi, pengalaman kerja, serta research dan pengabdian masyarakat yang beliau lakukan. Untuk mempersingkat waktu, please welcome Dr. Gita Sekar Prihanti. Time is yours.
Okay, thank you, Dr. Risma. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Okay, semoga semangat ya. Okay, ladies and gentlemen, honored Dean of Faculty of Medicine, University of Muhammadiyah Malang, honored guest, keynote speaker, participant, and dear student, good morning. Magandang umaga, Mrs. Gailine. It is a great honor for me to welcome all of you today in International Guest Lecturer, Faculty of Medicine, University of Muhammadiyah Malang. I'm Gita and I will be your moderator for this session of academic journey. Ladies and gentlemen, the world's population reached more than 8,000 billion and 60% of world population are workers. So it is very important for us as medical doctor, as health practitioner, to pay attention and highlighting the occupational disease or occupational health. And at this event, we will learn from the expert. Ladies and gentlemen, please warmly welcome Gailine F. Manalang Jr., PTRP MOH. And before I greet our speaker, please allow me to review his CV. And we see the screen. Yeah, Associate Professor Gailine Manalang is physical therapist licensed in the Philippines and an occupational health professional, a graduate of the BS Physical Therapy and Master of Occupational Health Program of the University of the Philippines, Manila. She obtains her international qualification of for occupational health and safety from the University of Illinois at Chicago, USA, and from the National Examination Board in Occupational Safety and Health, UK. As we can see on the screen, Professor Manalang currently teaches graduate and undergraduate course in occupational health and public health in the university. Her main faculty research pursuit has been with PhilSIF, an interdisciplinary group from the University of the Philippines and LMU Munich, Germany, that developed chronotyping tools for Filipinos. And this multiple research project completes her unfinished doctoral dissertation, in which she started at the Ludwig Maximilian Universität in Germany. So, ladies and gentlemen, without further delay, please give warm applause to Associate Professor Gailine F. Manalang Jr. Time is yours.
Thank you, Dr. Gita, for the very nice introduction. Our head of the PPD, Dr. Anong, members of the faculty, and staff of Facultas de Doctoran, and of course, our very special group here, our new medical students. Salamat pagi, good morning, and magandang umaga in my language. Anyone here has been to the Philippines already? I should bring all of you there, huh? Okay, but let me convince you first that you can indeed go to the Philippines and study with us. I am very honored to have been invited to introduce to you a professional practice that very likely most individuals who set out to do healthcare study did not realize existed. Okay, so for sure, you are similar to my students in the Philippines, that from a lot of you from very young age were thinking already of going to medical school. Maybe some of you have parents who are doctors themselves. Maybe you're inspired by someone you met who happened to be a doctor and you aspired to be the same. Okay? I was like that also when I was young. And eventually, I decided to not pursue medicine to ensure that my sisters also got to go to school. Now, my father was the one who recommended that I study physical therapy. Okay? So it's for him recommendation because he underwent physical therapy for his knee injury. And he told me that this could help you decide if you want to go to medicine, because you see the lifestyle in the hospital and the clinic. So it was a good compromise. I came to love physical therapy, and then it brought me to my current field, which is occupational health. Okay, so how many of you have heard of the term occupational health and safety before you were told of the announcement of this lecture? Anyone already encountered the term? Show of hands, anyone? Don't worry, I will not call you for recitation. Okay, so very rare is a new medical student that already knows of the field. Okay? And if you are one of those rare Pokemons, I hope you continue to go into this practice. Health and safety was before a very obscure concept in professional practice, not so much appreciated. But when the pandemic happened, everybody suddenly became conscious of how important it is to keep workers healthy. We would not have recovered from the pandemic as fast because if we did not take care of the essential workers. And many of the public health measures in different countries that help us come out of the pandemic were actually occupational health and safety measures. Next slide, please. Okay, so in this session, it's my privilege to introduce to you the practice where we actually are in preventive practice. Okay? At the end, I would hope that you are able to define what occupational health is in terms of what the aim of the professional practice is, in terms of the disciplines and professions that are involved, and that includes your future profession, and what the relationship of occupational health to safety is. Okay? We hope that at the end you'd be able to discuss the process of promoting health in workplaces. Dr. Gitra mentioned earlier, 60% of the world's population are workers. That's the kind of population that you will be taking care of later on. You will not encounter them only in the hospitals. You can take care of them in their workplaces. So you have to be familiar with how the workplace can be set up for healthcare in following the principle of prevention. Okay? So that's one difference that practicing in hospitals and clinics would have with practicing in workplaces. In a hospital and clinic, it's likely you encounter individuals who are already with some illness or disorder. But in the workplaces, you encounter basically healthy population with a certain segment or certain number who might be suffering from a work-related condition. But a lot of them, a lot of workers will be healthy. In epidemiology, that's called the healthy worker effect. And you have to take care of the healthy ones also. Does it make sense that you take care of the healthy ones so they don't get sick later on? Yes. Individually, that's what we also do. We take care of ourselves. But when you go to a workplace, you encounter special factors or experiences that could increase your risk for an illness or disorder. So you have to be aware of how you can promote health in workplaces. You will also be able at the end to describe not only the typical occupational health setup, which is having an occupational health unit in a company, but other ways that you can provide the preventive services in occupational health. And lastly, you'll be able to define what the function of such a service is, as well as who is there to make the service possible. Okay. Next slide. These are the concepts that we will be going through in this session. And of course, the first part of our morning will be very lecture-like. I'll be very much happy to take your questions later on after the session with the moderation of Dr. Gitra. Next slide. Okay. So this practice stems from a right. Okay. You're likely familiar with the Universal Declaration of Human Rights. Beautiful document came up in 1948 by the United Nations, which outlines all the different rights of people. And the 23rd article of the Universal Declaration of Human Rights is about work. Basically, that all of us have the right to work, to free choice of employment, and just and favorable conditions of work, as well as protection against unemployment. Okay? That very much underscores the practice of occupational health, that where we work should be just and favorable conditions, conditions that keep us healthy, safe, and even happy, and that we are protected against unemployment, not us not being able to be contributing members of society. The other expressions of the article have to do with worker welfare and labor rights too, so that you are not discriminated against, that you are basically entitled to the same pay for the same type of work that your peer does, that you are able to enjoy just and favorable remuneration from the work that you put out, because you need that remuneration not just for yourself, but for a dignified life for your family as well. And lastly, that you have the right to form groups or unions that will further your protection and your rights. Okay? So occupational health stems from the first expression of this universal right. Next slide. There is a further document from the ILO this time, which explains more about the right to work and specifies what these specific rights are in the context of a workplace. The first four have been around for decades, since the Declaration on the Fundamental Principles and Rights at Work was published. But it's only during the time of the pandemic, for some reason, 2022-2021, that the fifth principle was promulgated. And it's a principle of having a safe and healthy working environment. I believe the appreciation of the fact was driven home because of the experience of the pandemic. Again, we had a very difficult experience then. Everything had to suddenly change, the way that we work, the way that we studied, and economy had to change its way of working, because we were dealing with an invisible war, a biological agent. Okay? And we gradually had to bring back our workers to the regular way of working, with protection for them from becoming sick. Okay, so this fifth fundamental principle, although very much appreciated already, was only enshrined as a fundamental principle within the past few years. Okay? So it also directs, therefore, professionals to a new practice. Okay? So not so new, let me correct myself, not so new, but we are more conscious now that there is another practice that we can venture into, especially for a healthcare professional, and that's to promote safe and healthy working environments. Next slide. Okay. So occupational health as a practice of different professionals is concerned with preventing ill health in the employed population, 60% of the world's population. And it might even be higher than 60%, because we have to account for those who work in smaller industries, those who don't work continuously. Okay? This is the gig economy nowadays, right? So not everyone works in an office or goes to a certain place for their work. There are those whose work is portable. For as long as you can find connection to the internet, you can bring your work with you. So that I think that 60% number is what could be established in surveys, but not necessarily the truth. Okay? Different way of working also is that before, most workers are legally allowed to work 18 years old and above. But we know that there are industries that children also participate in work, right? And with online work too, you can be doing online gigs. You might be a vlogger or an online seller. Those are also new types of work. So putting occupational health into these different work contexts, your main aim would be to prevent rather than cure ill health or disorder wherever it may arise in the workplace. Okay. So different illnesses, different disorders that come about because you are exposed to something at work. Okay? When you are in the practice of occupational health, you very much take to heart the principle that there is a two-way relationship of work and health. What does this mean? Do you agree that your health will affect the way that you study? And how you study will also affect your health? Yes. If you substitute the word work for study, that also is what I'm talking about. Health affects our work, and the way that we work affects our health. Next slide. We not only prevent ill health in the population, we also set up the workplace in a way that it will be conducive to good health, to prepare and preserve the conditions in the workplace so that you reduce the risk for any disorders, that you protect your workers in their place of employment from the factors that could cause them poor health. And lastly, that we are able to place and maintain workers in an occupational environment that is adapted to their physical and mental capacity. That last one, I also advocate for very much as a physical therapist, seeing persons with disability. And there are those who are born with their disabilities, but have some ability that still will allow them to work, but not all would be able to appreciate. There are those whose disabilities are because they suffer some illness. For example, a stroke, okay? Or maybe an accident where they have an amputation of a limb or some other physical disorder. Okay? They are otherwise able to work. Question is, how can we match a workplace to their abilities, given that they are differently abled? So in the practice of occupational health, when we say healthy worker, we are thinking also of those who have disability but can do some form of work. We would like them to pursue work so that they are contributing members of society, so that their life is as dignified as those as able-bodied people. Next slide. Okay. So, likely you were thinking of going into medical practice, taking care of those who are not well. Okay? In occupational health, we have that in mind too. Doctors like Dr. Indra, Dr. Febri, who later on become specialists in occupational health and occupational medicine, would think about those who are unwell. And on top of that, they're also concerned about those who are well, that they do not become unwell. Okay? So we explain the work and health relationship this way. When you have a group of workers and they're exposed to the same possible, to the same factor in the workplace that could get them sick, that group will come out of that experience with different outcomes. If we talk first about health outcomes, everyone here, if you're exposed to factor X, okay, some of you will not suffer anything from being exposed to factor X. Then there will be those who are not aware, but it has started some form of disorder in them. And for a certain number of you, you will right away demonstrate some sign or symptom of illness. And unfortunately, and we know this from epidemiology, for certain types of factors or exposures in the workplace, the outcome for some will be death. Okay? So what we like in occupational health, what we aim for is that we minimize the poor health and death outcomes, that we keep everybody as healthy as possible. What explains the variety of outcomes? It's not just the parameters of the exposure, parameters such as the variety of chemicals that you actually experience, the variety of different natures of hazards that you encounter, how long you encounter them in the workplace, and how much they are present. So it's not only that explains the variety of outcomes. We have to go to the individual characteristics of workers. In your medical training, you will be taught how to do interviews to get important details about the health history of your client or your patient. And in specialty practice for occupational medicine and occupational health, you always ask questions related to the individual's pertinent past history that could affect their current situation. One example that is my favorite to say has to do with shift workers and how one can adapt to shift working. Born out of that project that I did with a faculty in Germany, studying the circadian rhythm. You're familiar with the circadian rhythm for sure? It's the 24-hour biological rhythms that we experience. And perhaps the one that we all could relate to right away is your cycle of sleep and activity. Okay? So that circadian rhythm is present in us all, but we have different types of circadian rhythms. We call them chronotypes. Those chronotypes are influenced by genetics. So if I would like to understand the health outcome of a group doing the exposure of shift working, I will inquire in their health history about their timing of sleep to ascertain what their chronotype is and then to see how risky it is for them to do shift working. So if you're in this practice, you have those special questions that you ask, not just about their socioeconomic background, their psychosocial characteristics. You inquire about genetics. You inquire about habits that they have learned over the course of their life. You inquire about past environments that they have experienced. So yesterday, I had a class with your upperclassmen. They are the nearly graduating medical students. And I learned from them when I asked them how many environments have they lived at up to that point. The answer was maybe 3 or 4 different schools that they have gone to. Okay? That is relevant to your current situation. Where if you're a worker, you think about or you ask after how many work environments have they been to in the past and what they were doing in those environments. Because sometimes the outcomes could be explained by an accumulation of experiences in different workplaces. That could help explain why the worker's experience now might be coming about. So it's not just the immediate exposure in the current workplace that you're interested in. You will be asking after prior workplaces and prior environments. Next slide. Something that's also exciting in occupational health is that we're not just concerned about health outcomes. We have non-health outcomes that we also manage. Next slide, please. These non-health outcomes have to do with how workers perceive themselves and the quality of their work and their relationships at work. So these are not necessarily health outcomes, but workers ascribe them or identify certain exposures as having caused them. For example, the pandemic, we were compelled to suddenly do work from home. When before, you would go to some place to do your work, and then at the end of the day, you go back home. So for a time, with that new setup of working imposed on us, there was a change in levels of productivity. For faculty, it's the frustration of working slow because you have to learn using the online facilities. When before, you would just go to the classroom, stand in front, and deliver your lecture. because it's automatic to you. It's a familiar environment and a familiar teaching strategy. But because of the change in environment, you had to develop a new way of working. And that has some effect on your productivity level. It has some effect on your behavior as well. And you can say whether there is some dissatisfaction at the way that or the level of working that you're doing. Also the sense of control. So workers very much value the fact that they can self-determine how they do their work. They take pride also in being expert in their way of working. But if something happens in the workplace, it's something that they're exposed to, makes them slower to move, or makes it more difficult for them to adjust, then their sense of control diminishes. And that's something that you are also contending with in occupational health, a non-health outcome. Next slide. Okay. So why do we prevent these exposures in the workplace? And I'll bring also the term accidents into the discussion now. Why would we prevent accidents, illnesses, injuries, and deaths? First and foremost, deaths or destruction or imperiling human life is not morally justified. Okay. Second, when you are an employer and you fail to take care of your workers, you are morally responsible for what you do. Third, when you have occupational incidents, this limits the efficiency and productivity in the workplace. And when you limit efficiency and productivity, what suffers is either the service or the product that your workers turn out. And that service and product is depended on by people, by the community. So if you have incidents in the workplace that affect efficiency and productivity, eventually it's the community that suffers. Then, if you have accidents and illness, the effect is not just confined to the workplace or to the individual worker. Remember, they live in communities. They are part of families. Something happens in the workplace, the effect will also be in the families and communities of those workers and those companies. Okay. And lastly, since we have all these developments and innovations in technology, when we design new devices, new machinery, it is engineered to be the best possible it can and the safest that it can be, the safest that it can be. We use the phrase engineer out the hazard so that, for example, your devices now, your mobile phones and tablets and computers, these are the best in design, not only because you can use them well, but they are the safest that you can use them. Do you use the blue light filter of your gadget? Show of hands, who uses the blue light filter? Who doesn't use? Show of hands. Okay, you know why there's a blue light filter? Are you familiar why there is that feature? In the spectrum of light, the blue light is the one that our brain reacts to the most and influences the circadian rhythm. If you don't filter out the blue light and you keep being exposed to the artificial light from the screen, the effect is that it delays the expression of melatonin and it later on delays the start of your sleep. So the phones now, most devices would have that filter built in, so that effect is minimized. Okay, so take advantage of that, especially you will be studying late in the night too. Okay, so what we're saying is that when we have these technologies and innovations that make make things safe, we have to make use of them, okay, to reduce accidents and severity of illnesses. Next slide. So basically, we have moral, legal, and economic reasons for maintaining the state of health of our workers and the healthiness of workplaces. It's not only effects on the workplace or the workers that we have to manage, we also have to ensure that the services and products that they turn out for the community keeps being turned out so that our communities and the country will continue to be productive. Next slide. There are what we call direct and indirect costs to just allowing workplaces as they are and not managing what we call the occupational hazards. Okay, so the direct costs have to do with basically increasing the costs in operating a workplace. And the indirect costs have to do with the impact on those outside the workplace, including the communities. So since we have limited resources, there is no institution that has unlimited resources. We have to ensure that we have sustainability. And when we have occupational health in the workplace, it's a strategy towards sustainability of industries, of people, and of communities. Next slide. Okay, so a related field is occupational safety. Safety is a jargon, or safety is a word that all of us would be familiar with, even more so than occupational health. In safety, what we are concerned about are accidents and what we call near misses. Okay? Accidents, clearly we understand. When something happens that causes physical harm, damage to property, stopping the work or actions that you're doing, those are possible outcomes of accidents. Often it's a combination of them. But the near misses, okay, we're also interested in them. Maybe if you drive, you appreciate the idea of an almost accident. So near misses are almost accidents. Nothing happens, no injury, no damage to property, activity doesn't stop, but near misses are highly indicative of future accidents, so we wish to also avoid them. When you avoid near misses, you avoid accidents in the future too. So in occupational safety, you manage what we call risks. We also manage risks in occupational health, basically the risk of an outcome being seen after an accident or an exposure. Okay? Exposures are the situations in the workplace where you have a hazard present or where there is a risk. So that we have strategy in occupational health called risk management. We cannot eliminate all hazards in a workplace. Some processes have inherent hazards that you cannot yet take out. Technology is not with us to take out the hazard yet. For example, can you imagine doing injection with a blunt needle? There are some devices now that are different type of needle. But for most parts of the world, it's still the conventional needle that we use, right? So with such situation, you have to work with what you have. But you have to minimize the risk that the needle will harm either a worker or a client. Okay? That's risk management. Next slide. Okay. When we protect worker health, this is basically the process that we undergo. We identify hazards, we do the risk assessment, we intervene with the management or the administrators of the company. They have to support what we call control procedures. These are special strategies of either engineering nature or administrative nature. In healthcare, we're very much familiar with the third type, which is the personal protection. Okay? Using masks, coveralls, etc. Okay? So there are many different types of personal protective equipment for different types of industries. They're all control measures. And lastly, when we implement controls as a result of the identification, assessment, and intervention, we also review and audit how effective your control is. Okay? Still along the line of sustainability, there are hazards that we expect will always be there. And there are hazards that we can eliminate. Okay? For the hazards that we eliminate, we have to be sure that they're eliminated. And for the hazards that we just aim to minimize the risk, then we have to be sure that we have indeed minimized the risk of outcomes. So we review and audit whatever programs we implement. Okay? Next slide. Okay. So what are these hazards that I have been talking about? We teach it this way in our graduate program in occupational health. This is not the only way that you will encounter discussion of occupational hazards, but this is very much our way because it complements certain, shall we say, principles in health sciences. Okay? So we define hazards to health as having two classifications, either hazard to health or hazard to safety. When you say hazard to health, you're concerned about situations of exposure to biological agents, physical agents, chemical agents, and ergonomic risk factors. Okay? So they're hazards to health. The effect could be right away, instantaneous and acute, or it could be insidious and delayed for as long as you're exposed to the hazard present at a certain level. There is what we call acceptable limits. And these acceptable limits are specific to different types of hazards. For as long as the acceptable limit in a workplace is present, then you have less risk of the outcomes. Okay? But if you keep on being exposed to the agent without the risk being diminished, then the outcomes will be there. Then you have the hazards to safety, wherein the natures are either unsafe conditions and unsafe acts. Sometimes they involve hazards to health, but the situation wherein the outcome is seen is the situation of an accident. Okay? So for hazards to health, for natures, you encounter them in exposures where you violate acceptable limits. For hazards to safety, you encounter them or they play a part in accidents, and they are either unsafe conditions or unsafe acts. Okay? So going back to the example of a driver, isn't it there's a safe way of driving? Someone who is oriented to the safe way of driving, but does risky driving, is doing an unsafe act. Now, if that driver was not taught at all how to be safe on the road, then what you have there is unsafe condition. Lack of awareness of a worker on safe practices doesn't mean that they're doing unsafe act. Something led them to be unaware. So there you have lack of education or lack of training. Those are unsafe conditions. In the same way that you don't provide PPE, for example, to the healthcare professional, that's unsafe condition also. Again, going back to the example of a car, if the car has a feature that makes it unsafe, you have machinery that's unsafe, that's an unsafe condition too. Okay? Next slide. Okay, so this is a visualization of how the classification and nature are related. So 4 types of hazards to health and 2 types of hazards to safety. So for physical agents, we have extreme temperatures, radiation, noise, vibration, atmospheric pressure in the environment, lighting, and also ventilation. Okay. Then biological agents would be infectious and non-infectious material. For us in healthcare, we see a lot of, or we encounter a lot of the infectious agents. Just by virtue of you interacting with another person, even if they're healthy, there's potentially the exchange of infectious agents there. Okay? Then chemical agents. So in industry, we encounter chemicals that are unique to that setup only. Some chemicals in workplaces, we will not encounter at home. Many of them, actually. Those we also encounter at home, likely we see in workplaces in higher concentration or in greater volume. So chemical agents in the workplace, we keep an eye out for them because they can induce effects in the body, different routes of exposure. And then you have the ergonomic risk factors. So these ergonomic risk factors have to do with compatibility of either a workplace or a device or ways of working with other people with yourself. Okay? So we look for incompatibilities. I go always to my example of the shift worker. In theory, the person who is night active or an owl will be the best suited and best match to night work, right? Who's the night owl here? Who identifies as a night person among you? Very rare in the population, less than 10%. So you're suited to night work, but if we are going to staff the hospital with only you, the hospital will not work. Very likely those who do shift working are day people also. So we have there a mismatch of the circadian rhythm and the shift working scheme. What do? We find ways for them to all be able to work despite the mismatch, without hopefully any effect or minimized effect on their health. Okay? Then the hazards to safety, again, you have unsafe acts or unsafe conditions. Next slide. Okay. So here's a challenge. How many hazards can you find in this photo, which I borrowed from the Health and Safety Organization in Australia called Safe Work? How many hazards do you see, or what hazards do you think are depicted in this photo? Anyone? You have any volunteer? We can take 2. And likely don't know each other yet. This would be a nice time to introduce yourself and give an answer.
Bisa diidentifikasi faktor risiko dan faktor bahaya di gambar itu, Dek. Silakan, volunteer ya, silakan.
We have gentleman on this side of the room. And after him, any volunteer?
Tebak-tebakan gambar, Dek. Yang mana, Dek? Ayo. Silakan ke depan, Nak. Yang tadi.
Okay, so this situation is a hospital situation. Okay, so you have different things going on there. Sir, what do you see as hazardous?
Assalamualaikum warahmatullahi wabarakatuh. Good morning, Professor Manalang.
Good morning.
Magamang Umanga.
Wow, perfect. Ganda umaga.
First of all, I would like to introduce myself. My name is Anal Azam Hakim, but all of my friends used to call me Azam. And I noticed there's 6 kind of hazard in this picture.
6 right away, huh? Quick inventory. Okay.
First one is the cable, and there's someone's fighting here.
Right.
And then there's a leak of water.
Okay.
And there's a trash bin.
Okay.
And the bed is kind of, how would I say it? Covering the patient.
The bed is covering the...
Yes, and then...
Did you mean the bed near the wheelchair or the bed at the back?
The bed near the wheelchair.
Okay.
And then the door, and the other bed is covering the door, the exit door, the emergency.
Okay.
I think that's it. Thank you.
Thank you, Dr. Azam.
Not yet, but thank you.
No, we claim it already. You're Dr. Azam, Occupational Medicine. Okay, perfect. So, you have a sense of how an occupational health professional works. When you come into a room, you scan it already and like to look for those that could lead to outcomes. Those that could lead to accidents, those that could lead to illness. Sometimes the hazard has to do with interaction of people. In hospital and clinics, you encounter sometimes difficult to manage patients and their caregiver. Okay? Then there's also the fact that when you evaluate a workplace, you also have to think about non-routine situations, especially emergencies. So emergencies happen, they're unpredictable. It's critical that we ensure that the emergency measures are fail-safe. In this situation, we see the bed in front of the emergency exit. It may just be a few seconds to remove, but those few seconds matter when you are managing an accident. When people are in panic, sometimes they don't see what needs to be done right away. And people can interfere further with saving yourself in an accident. Okay, good. Next slide. One thing that we keep in mind in healthcare establishments when we talk about health and safety is that you have a variety of services there. And that variety of services, the more you have in a healthcare facility, the more complicated the health and safety concern is. You'll be experiencing working in acute and long-term care facilities, different setups where there are outpatient clinics, surgical clinics or otherwise, that they have laboratories of different kinds, that you have pharmacies in the for inpatient and for outpatient. You have imaging units, you have ambulance emergency care, and then of course you have the offices for the medical and non-medical staff. Some facilities might have home care services. So the more functions you have in healthcare, the more complicated it is to manage health and safety. Not to mention that, next slide, you have all these other support units. Okay, those units that are necessary to continue the service in the hospital, like those that are health service aides or assistants, those that provide food from the dietary or the pantry, those that provide personal services to the clients, and also laundry services, building maintenance services, security, transportation, and down to mortuary care. Surprise, surprise, those who work in the mortuary are also healthcare personnel. Okay? You may be doing direct patient care, or you might be a little more removed in that you are in the laboratory, for example, or you're doing research in a hospital, not necessarily taking care of the patient, but implementing some special function. For most of us, we will experience being students and interns in healthcare, or maybe a volunteer because you want to enhance your experience. All of them will be beneficiaries of health and safety. One principle we go by is that the health and safety program will be for all who act in an institution, including students, interns, and volunteers. Okay? So it's not just confined to those who are actually employed by the establishment. You have to extend health and safety services to everybody. Okay? Next slide, please. So how do you organize these occupational health services and who staffs these services? Next slide. The service for occupational health is essentially entrusted with preventive functions. So we're responsible for not only taking care of the workers, but also advising the employer on how to go about taking the workers. The occupational health service acts so that it allows, or the establishment is able to comply with regulation for health and safety. Indonesia and the Philippines had promulgated their health and safety law, as I understand it, in the same year, 2018. Okay? So you have a national health and safety law. The health service is the one that assists the company to comply with the law. And also, there is the function of the health service, the occupational health service, adapting the workplace for all who work there. Okay? So again, that goes for the able-bodied and the disabled individuals. Next slide. Okay. Many functions of the occupational health service. I just give you in my handout the source of this listing of functions. But the variety of functions listed here and in the next slide, please. So this variety of functions reflect the different character that an occupational health service might have. Occupational health services are set up in relation to what is needed in the workplace. Okay? We may have two companies with occupational health service, but between them, there would be differences on how the occupational health service will be working, because how they are set up will respond to what is present as hazardous in the workplace. Okay? So it's not only that we take care of anyone in the workforce that is sick. There is a function of the health service, occupational health service, in complying with regulation, the function in making the workplace accessible to disabled individuals, the function in making available first aid and emergency services, and also the function of monitoring hazards, illnesses, and diseases among workers. Much in the same way that we have the public health system and we monitor communicable and non-communicable disease, in workplaces, we have such monitoring too. Something that we keep in mind is that in workplaces, we have healthy individuals, okay? There's what we call in epidemiology, the healthy worker effect, okay? And that we monitor the state of health of the workers to find out immediately, see indications or any trends if there are suddenly increase of either risk or poor health in the workers. Next slide. Okay. How do we staff such services? With the service being set up unique to the industry, the staffing will depend on also what the functions that service will have. I put an asterisk on the occupational health physician, occupational health nurse, and the industrial hygienist, as they are in many places the core members of the occupational health service. So this is where I put forward again the idea that this is a career path for you. Okay? But between the three, again, in many places, it's the occupational health nurse that the workers know very much well. They are the one who is usually full-time in the workplace. The physicians are not necessarily full-time in companies. In the Philippines, the regulation does not require full-time physician for all companies, except companies that have more than 2,000 workers. Okay? If less than, you can have part-time physicians, and they would be on call when they are not on site. When they are on call, who calls them? It's the nurse. Okay? So the workers are most familiar with the nurses. And the industrial hygienists, we don't have as many of them as we would hope. It requires very special training. Some doctors later on go take that training to become a certified industrial hygienist, and they're the ones responsible for measuring different factors in the workplace. So you have the function of being physician, and you have the function also of industrial hygienist, where you basically evaluate the workplace and you diagnose, in a sense, the workplace for the risks. Okay? The other professionals that you may find in occupational health service will depend on the rationalization of the company in what they see in what they call hazard identification, risk assessment, and control, or the HIRAC. Okay? So you may have a large occupational health service for a company that is very much into occupational health, and then you may encounter companies that have a very lean or small service in only that they have the core members. Okay? Next slide, please. Okay. These are the different models where we find occupational health services dispensed. The stereotypical model is that of the in-plant or in-company model, where you have the service right at the work site. Sometimes, work sites with same nature of work will share one occupational health service, and we call that group or inter-enterprise model. Okay? There's a special type of it, which, next slide. So this group or inter-enterprise model will be shared by multiple companies. If those multiple companies have basically similar concern, then you have industry-specific or branch-specific model. It's a specialized practice for industries of similar concern. Then, next slide. There's also the model where in the hospital, there's an occupational health service. Sometimes it's called the industrial medicine service. Have you heard of that before? Okay. Industrial medicine is the older term of occupational medicine. And some hospitals set up an occupational health service for the companies around it and for the what we call informal workers. Okay? So context of company is that you have formal workplace. Informal informal workplaces include agriculture, fishing, those who rely on primary health care. Okay? And for those who have work-related injuries in such industries, they are fortunate if there is an industrial medicine clinic in their local hospital. That's very rare. Then there's the model where we have the private healthcare center. So you have a group of doctors who have some training in occupational health, and they put up their own service. Now, the disadvantage of the hospital-based and primary healthcare center is that they are not at the work site. So when you see the patient or the client, you don't get to see how they work to identify root causes of their situation or their outcome. You won't be able to assess the workplace for the exposure or the near miss that led them to consult you or even the accident. Okay? So next slide. When that is the situation, you have to work with the occupational health service on site. So that's an exciting aspect also of occupational medicine practice. You get to work with different people in different setup. And suffice to say, you have to be people person. Okay? Then there is the primary healthcare unit service where you have occupational health professionals in the public health system. Okay? In the Philippines, we have the barangay health clinic, okay, and the municipal hospital. Okay? So rare model, we don't see much occupational health service in those setups. And lastly, social security model. Okay, so you remember in one of the principles of the expressions of the right to work, that we are protected from unemployment. In the event that we become unemployed, and especially if we get sick, there is social security that should come in to assist us, to give us some compensation while we are trying to recover, and to give us assistance when we go rehabilitation. So that's the social security model. It comes from the social security body of the government. Next slide. Okay. So these occupational health professionals are people who are accredited to practice a certain profession, and on top of that have gained competency for providing occupational health services. They are not necessarily full-time in the profession. They are not necessarily employed by companies. They can be working on consultancy basis and only part-time. Okay, so anyone who has a profession and then has the additional qualification for occupational health, we call them occupational health professional. There are countries that actually have a Bachelor of Science in Occupational Health. Okay, I'm not sure, I think in Philippines and Indonesia we don't have. We have the Bachelor in Public Health, right? But there are countries that have seen the need for a bachelor's degree in occupational health, not necessarily master's degree. Next slide, please. Okay, so many roles of the occupational health professional depending on the occupational health service and the nature of the industry. Next slide, please. And we determine the staffing I mentioned earlier, depending on the nature of the industry, the model of the service that is necessary. It depends on the need in the workplace based on the type of work that is there. For service industries, much of the concerns are of work that have ergonomic concerns. So you need an ergonomist in the occupational health service. Or you might find that the nurse, the doctor, or some other staff have done advanced training in ergonomics and they stand as the ergonomist. Okay? So the type of work involved dictates the type of hazard and the type of staff that we need. It also depends on what the standards and requirements of the law will require us to have. Okay? In Philippines, the minimum occupational health service has to have occupational physician, occupational health nurse, occupational dentist, and the first aiders. That's our minimum according to our law. Then you have to have availability of the different specialists. Hopefully that you have someone in touch or you have someone in the network that you can invite on consultancy basis for specific functions of the service. And lastly, it also depends on how well-resourced an establishment is. Occupational health is what we call a cost item. In a company, it appears to be just expense. You spend for people who don't contribute to the service or making a product. So in the past, it's not much appreciated by companies. But when the pandemic happened, that's when they realized that the occupational health service is actually the one that helps the company get back to business. So now it's better appreciated. Next slide, please. Okay. So we do a hazard inventory to identify what puts us at risk. We look at the workers, the materials being used, the equipment and its features, processes, and what would be existing hazards. Next slide. Okay. And for this, we adhere to principles of another field which we call industrial hygiene. Next slide, please. Industrial hygiene is another specialty. And the principles of industrial hygiene we use as principles in occupational health also. So we've gone through the process of protecting worker health earlier. I'm nearing the end of my presentation and will dwell more on the key principles as inspired by industrial hygiene. Next slide, please. So industrial hygiene has 4 principles: anticipation, recognition, evaluation, and control. Okay? In respect the hazards. Okay? When in industrial hygiene practice, you are in a practice that is also involved in measurements of to prevent the diseases or disorders that you might see in a workplace. It's also known as occupational hygiene. So if you encounter these terms separately, they're one and the same. Next slide, please. Okay. So when we anticipate, recognize, and evaluate and control, we go through a process wherein we try to rationalize what needs to be done in the workplace. It involves specialized training to be able to do these processes. Next slide. Okay, so the first one is to anticipate hazards. It might not be available, the access to workplace might not be available to you, especially if you are in a service outside of the company, like the one in primary healthcare center or in the hospital, right? So when to anticipate hazards, what you can do is review scientific literature and workplace records of past accidents, of any illnesses in the workers. This one is coming from a study I did 15 years ago on different hazards in 11 hospitals under our Department of Health or the Ministry of Health. And we were implementing a training on health and safety. Our participants had no training before that. And this is what they enumerated before we started the training. So they are not from health background. They're not from occupational health background or industrial hygiene background, but they could identify these hazards in their hospitals. So I would like to drive home the point that all of us have an instinct for what could make us unwell. Just like our participants in this training, even if you've not had the specialized training, you have an instinct for what can make you unwell, and that will help you if you become an occupational health professional later on. So anticipation is not just reviewing literature, you can review work records as well. Next step would be to recognize the hazards. In anticipation, you think about the possible hazards. Okay? In recognition, you actually then go to the workplace and look for them whether they are present. Next slide. Okay. So in recognition, sometimes you go right away also to evaluation. Recognizing hazards, you bring yourself to the work site. What you know to be there because of literature, you try to see if they are present. That's recognition. Often when you conduct an ocular inspection. And when you verify that they are present, your next step would be, next slide, to evaluate them. Okay? When you evaluate the hazards, you take into account what we call standards. Remember what I mentioned earlier about acceptable limits? We have what we call also occupational health and safety standards. Basically, these are rules that say for a certain occupational hazard, this is the level that it can be tolerated or allowed to be present because we know from study it is unlikely to cause illness. Okay? So when we evaluate them, we use special instrumentation using standard procedures to come up with measurements that we look against standards. Okay? So what we see here on the photo on the left, you have an industrial hygienist in a work area where they are evaluating for, let me correct myself. I changed this photo. This photo is about a worker doing some dusty work. And you see something on his belt, right? Okay, that device is basically an air-moving device. It sucks air into it. You see there is a transparent tube going behind him. And that transparent tube is actually hooked near his nose. So that device, we call it an air sampling train. At the end of the tube, near the breathing zone, there is a filter. And you have the worker use this while they are doing their normal work. You retrieve it after a certain time, and then you bring that filter cassette to a laboratory where you either count the dust or do analysis on the dust to get the composition. Okay? And then you have standards to compare your measurements against. Is it excessive dust, or is there chemical that is too harmful that we need to remove? Okay? The other situation, you have that, well, I'm sorry, it might be too small a photo, but that's what we call a heat stress monitor. It's on a tripod. It's maybe as big as this camera, and then it has 3 sensors. Okay, they're all thermometers. One measures radiant temperature, meaning heat coming from different bodies around. Another measures dry air temperature, regular thermometer. And then another is a thermometer that we call the wet bulb thermometer. It has some cloth at the end, a wick, which is wet. And what it measures is temperature against evaporation. So it measures heat stress using 3 values that we later on compute an index for. Okay. If you're familiar with the heat stress index that weather agencies routinely publish about, this is how it's measured. And you use the same device to measure for heat stress in workplaces. Okay. So anticipate, recognize, evaluate. Sorry, that should be number 3. Number 4 is control. Next slide. So knowing which hazards are beyond acceptable limits, you then are able to rationalize what controls would be needed. We want to eliminate the hazards, but we can't always eliminate, so we can implement substitution, engineering, administrative control, and PPE. As much as possible, we aim to eliminate, but if we can't, what you see is the succession of what we know to be the most effective. Most effective is to take out the hazard, eliminate. But if you cannot, substitute it with the material with a less hazardous material, or you create an engineering control, design the work area to minimize the effect or the exposure on the workers. And down the line, the PPE is the least effective. Okay? When we implement controls, it's always a set, not just substitution alone or engineering alone. It's always a set. and we justify what that set is. Okay, next slide. Okay, so in this slide, okay, we emphasize again the effectiveness of controls. The most effective is elimination. Is also supposed to be of the best business value. We have to rationalize with the company why we need such and such control. Okay? Before the pandemic, it's difficult to convince companies to provide certain controls like improving ventilation. That's very costly. But when the pandemic happened, later on it's easier to understand because they see the business effect of stopping work. And companies are more open to providing controls. Okay? So you're not only a people person, to an extent you're also a person who is dealing with business people. You have to be able to demonstrate the benefit of protecting the health of the workers so that companies are convinced to spend for anticipation, recognition, evaluation, and control. Okay, so winding down in my presentation, the last couple of slides, next slide, have to do with the core principles of occupational health. Okay, so we'll just enumerate. First, we remember all workers have rights. Second, we have to establish policies so those rights are protected, occupational health and safety wise. When we have policies, they have to be enforced so that we can implement what is needed to protect worker health and prevent ill health. Then, we cannot implement them without consulting the different partners and stakeholders for a company. Okay? And among the stakeholders are the communities in the vicinity and the workers themselves. We have as aims in occupational health primarily prevention, but also protection of the worker. And we recognize that in order to justify prevention and protection measures, we have to have information. We have to know through anticipation and review of records, etc., and generation of information in surveys, what is needed in the company. Next slide. Okay. We all have health and safety responsibilities, duties, and obligations. Even if we are just visiting an establishment, our obligation really and responsibility is that we follow the health and safety policy there. We don't become hazards to others. Okay? So everyone has responsibilities, employees, employers, and even us occupational health professionals. Okay? Next, in our practice, we promote health. So you may encounter health promotion more in the model of providing primary health care in communities. But keep in mind this, of the 60% or more in the population that work, likely their setup is that they spend 8 to 9 hours of their time every day at work. Another 8 hours may be for personal matters, and the remainder of the time, hopefully at least 8 hours too, is for sleep or rest. Now, when we say primary health care, does it not stand to reason that we use that structure where people are at work for 8 hours and to promote health at the workplace? Okay. So it's not just that we are in clinics, in hospitals, or in the community to promote health. We also can situate ourselves in companies. Then, we promote education and training to, as being important components of safe, healthy work environments. On the very first day of the conference that I was invited to participate here 2 days ago, our vice rector, I believe, said we have to love what we have to understand before we come to love. And for workers and others to understand occupational health before they come, before they participate and come to love occupational health, they have to be educated and trained. and you become educators and trainers to them. Okay? Then occupational health services should cover all workers. And the last one I have highlighted because I would like you later on to remember this if you become an occupational medicine physician. In the service, you don't only provide services for cure. You also provide means for rehabilitation for anyone who becomes injured at work or for a disabled individual who would like to work. Okay? And lastly, your role also has importance in compensation. We cannot avoid accidents, all accidents in the workplace. There is, in accident theory, a certain chance of accidents happening by acts of God or unknown factors. And if it comes to that, despite all of our efforts, that there is an accident in the workplace and it was not controlled, your role as a physician is to help the worker get compensation and to assist the workplace to be able to respond to what the law requires. Okay? So with that, I would like to end my presentation. I'd like to thank you for your attention, and I am hoping highly that you have opened your mind also to the path of becoming an occupational health professional. This might be something surprising on your very first week as a medical student, because likely you came here thinking that you'll be working in a hospital or clinic or even your communities, okay? But open yourself to the idea of the workplace as being a community where you can be at too. You're very much needed by our workers, okay? Thank you everybody for your attention. Dr. Citra, if we have time for questions, you can take questions.
Thank you very much to our distinguished speaker for your insightful presentation. Now we are moving on the Q&A session where we warmly welcome questions. Silakan kepada adik-adik. Ya, silakan. 1, 2, 3. Kita sesinya 3 pertanyaan dulu ya. Oke, silakan.
Assalamualaikum warahmatullahi wabarakatuh. Thank you for the opportunity, Professor and Dr. Gita. Let me introduce myself. My name is Rosalina Al-Rahma, but my friend can call me Rosa. I will ask, in practice, many workers ignore safety and health because of deadlines or work pressure. How can we build a strong safety and health culture so protocols are not ignored? Thank you.
Thank you, Dr. Rosa, for your question.
Thank you.
We claim it for you that you will be a doctor too. Okay. How do we promote adherence to health and safety, and so that workers do not ignore? Okay. As an educator, my answer to that would be that health and safety principles be introduced as early as possible in education. Okay. So I find it very special that for you in medicine, on your very first week, you are hearing about this field. In other countries, they introduce occupational health even up to the elementary years. Not all the concepts that we had today, but relevant concepts like, for example, in certain states in the United States, they teach elementary age children about hours of study. And they explain it in terms of them being kept healthy. Okay? So the earlier that we come into familiarity with health and safety, the more likely that workers will take to or follow health and safety practices. Okay. I think with the benefit now of more consciousness, especially after the pandemic, people know what it means to be safe at work. Okay. Also with the benefit that we have all these different forms of media where you can put out ideas, right? Okay.
Yes.
I'm not a TikToker myself, but if you are a TikToker, okay, make some of your discussions about being healthy and safe. Okay, not just about typical health conditions. Make it include also there something about this can happen at work, or this at work can lead to this. Okay, so you might not be labeling it as occupational health, but it becomes more, people are more sensitive, become more sensitive to the idea of being safe at work. Okay? So do your TikTok with OH in mind.
Okay, thank you, Professor.
Thank you. The second question in behind.
Okay. Assalamualaikum warahmatullahi wabarakatuh. Excuse me, Professor Gaylin and Dr. Gita. Let me introduce myself first. My name is Jihan Kesharofia, and I used to be called Jihan. And today's my question is, before that, good morning, and ladies and gentlemen, good morning also. My question for today is, Professor Gaylin, considering the highly dynamic challenges in today's medical field, especially with the emergence of new technologies and changing patterns of healthcare delivery, in your opinion, which aspect of occupational healthcare professional or OHS are the most often overlooked or underestimated by healthcare professionals? How do you think we should anticipate and address this issue starting from medical education? Because in the future, we are here, will be a future doctor. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Okay. So thank you, Dr. Jihan, for your question.
Thank
so you're
you.
asking after what is overlooked in occupational health practice and what should be incorporated in medical education, particularly.
Yes.
Okay, good. One thing very relevant would be that we build on your strength, which is basically your developing clinical skill, right? I believe it's impactful if medical education will really orient your approach to taking medical history from point of view of occupational health history. Okay? So that has a lot of impact, not just in understanding whether the condition of the client or the patient is work-related. Later on, when that individual will need help for rehabilitation or compensation, the signed document from a physician matters very much, legally. In the Philippines, we have a list of what we call occupational diseases and compensable illnesses. If you see a patient in the clinic and they have that condition, it's automatic. They can avail of compensation. But there are so many new technology, new exposures nowadays that for the worker, they know something at work got them sick, but it's not among the legally recognized compensable condition. What would help that worker? It's the documentation of the physician, that they are able to establish the exposure, that they are able to draw from the history that it's not anything personal that caused it, but rather the circumstance of work. Okay, so if there is anything that we can incorporate, which I feel will be impactful in your study as physicians, it would be that approach to taking the history of the worker, a strategic way of documenting environments and past work and past exposure. Thank you.
Okay, thank you, Doctor, and thank you for having you here as the wonderful speaker today. Thank you.
Okay, thank you. For the third question, please. Yeah. Please raise hand. Yeah.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, Professor. Let me introduce myself. My name is Muhammad Riazmi Rasya, and my question is, beyond the immediate risk, what are the long-term occupation health risks that healthcare professional face throughout their career? Thank you.
Sorry, Dr. Muhammad, thank you for question. You're asking about long-term risk of the healthcare professional themselves?
Yes.
Okay, okay.
Thank you.
I go to my favorite topic, which is us experiencing extreme work hours. Okay, so it's not only that you do night work in shift working. Extreme work hours means also that you work more than 8 or 9 hours a day, long work hours. Okay, and in healthcare that cannot be helped. There are many that need our service. Okay, the fact that we do that type of work over the course of a certain number of years is something that in many studies can be demonstrated to have an effect on our health. Okay? But as I explained earlier, we cannot help it because if we just take to the idea that we choose when to work, maybe because of the chronotype or because of other things, okay? We will not be able to make the hospitals and clinics work. Okay? So what I advise really is that knowing that this can affect us for the long term, we keep on working, but protect ourselves as best as we can, rest as much as we can, and eat well and exercise. Okay? So much of what we experience in healthcare work has to do with the long-term consequence of not being able to rest well and eat well and exercise well. Okay. Thank you.
Thank you.
Okay, thank you. The fifth question. Yeah.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. My name is Ahmad Dhani Fauzi. I'm from Bali. Excuse me, Professor Gaylin Manalang. May I ask you some question?
Yes, very polite gentleman, huh? Okay. Yes, Dr. Ahmad, please tell us your question.
But Professor, I think my question isn't relevant to today's class material. Is it okay? Can I?
Just don't ask me how much money I have.
I'm not.
Go ahead.
Okay, thank you. For my question is, what is the best experience Professor get when you reach the best version of yourself?
Oh, what best experience can I say helped me reach my best version of myself?
Yeah.
Okay. So many experiences that I can say that right now is the best experience. It's really, I think, being able to see that whatever it is that happens, things work out. Okay, so some experiences, for example, while doing my PhD dissertation, my father and my mother got sick, I wasn't able to finish my dissertation because in where I live, healthcare is you need to be there. Okay? You need to take care of those who are sick. Okay? So I had that experience wherein I actually finished my dissertation, but I could not defend it. Okay. After that, I realized that even if I did not get the diploma, I was still able to do work. And the experience of taking care of my parents, I would not replace with anything. So also realizing that it happened during the pandemic, and I had the responsibility also of implementing health and safety protocols. So it was really tough time. And after that, I realized that I was caring for people more. Okay, because of those experiences that were difficult, I was caring for people more. And I never thought that I could care more because I really love my practice as a PT, as an occupational health professional. And I guess from that, I realized that for as long as you do your best and you remember that your constant is God and He will not leave you, you will always evolve into the best version of yourself, for yourself and for others too. Wow, that's an expected question from the floor. Thank you.
Me, thank you too.
Thank you.
Thank you, Professor. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi. Okay, are there still any question more? Okay. Okay, two questions for the last. In the back and in front.
Assalamualaikum warahmatullahi wabarakatuh. Permission, Professor Gillian and Dr. Gita. I want to introduce myself. My name is Budi Agung Fajar Biantoro. I want to ask about the pandemic, like Professor mentioned, and maybe it's a little out of the topic. If in the future the pandemic has come again, are we ready to survive from another virus? And are we ready to decrease the risk from the pandemic? Thank you.
Dr. Wudianto, thank you for your question. Now it's tough question. Earlier it was reflection, now very tough. Because it's very technical. I am not in infectious disease practice myself. We don't know what we have from prospective surveillance of likely or biological agents that might likely cause a pandemic. But I believe that this soon after the last pandemic, if we have the bad fortune that we have another pandemic, people are more ready because they have prior knowledge of what happened, right? And it's not difficult to explain the preventive measures and practices for those who have that experience. Okay? So what I think we capitalize on is that to prepare for the next pandemic, we don't forget our past experience. The last significant pandemic before the COVID one was 100 years ago. So that most people really are not aware that there was even a thing. Okay, so when the COVID happened, it was difficult to participate or understand unless you're a healthcare professional to participate in the measures, right? But now that most people are better aware because of the experience, I think to be ready for the next one, we don't forget the practices that we did to come out of the last one. Okay, so it's important that the practices that were effective be documented. The practices that were necessary for our families be remembered. Okay. I would say when you're in health and safety practice, you're in a preventive mode. Even at home, you're ready for anything. Okay, so if you're doing health and safety for companies, you have to also do it in your personal life. And for preparation of the pandemic, it might sound weird, but there has to be individual preparation for it. We don't wait for community or government to tell us what to do. Yeah, okay. So we look to our experts in infectious disease if there is such thing as prospective surveillance for biological agents. Okay, so if there is such information, it would help us anticipate what it can be, and it can help us better prepare. Okay?
All right.
Thank you.
Thank you, Professor. May I ask about another question? One question. All right. How you can explain something to some listener from different country and culture? Because it's my first experience to listening public speaker from another country. Thank you.
So you're asking for tips on how to communicate to someone from another country and another. Okay.
Yeah.
I've had the good fortune of being mentored by our parents and encouraged to study English. Okay. The reason for that was because my father was working in Saudi Arabia. And in the work in Saudi Arabia, he was with government. He's an expatriate employee. He could bring family to Riyadh. So while there, of course, different people, different community, not just Filipino, we were encouraged to learn to speak and write in English. So I had that advantage. Okay? I think it's still an advantage today that you are able to speak in English. There's also the advantage of technology, right? We can tune into different media, different people, different things, different cultures too, by remote using social media and online media. So my tip to be able to communicate effectively, whether you are a physician later on or in the community or in workplaces, would be to be aware of different culture and to learn some of the words of the cultures that you are interested in, okay? And also to bring your humor with you, because humor is universal. You know how to time a joke or to time a nice question, that's already communicating, okay? But there's still best effort to study new languages. Okay, so that's my tip. Okay.
All right, thank you, Professor.
Thank you. So the last question, please.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Good morning, Ms. Gailine F. Manalong, GR, PTRP, MOH, and good morning, Dr. Gita Sekar Prihanti, MPD, KUT. My name is Putri Salsabella Wijayanti. I want to ask about the relationship of the medical student. If there has past study in here, what do you think about, since occupational health focus of the prevention rather the cure or not the only cure, how can medical students integrate OHS principles into their future practice to protect both of themselves and their patient in the future? That's my question. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
So how do we integrate occupational health practice so that you can protect yourself and your clients in the future, right? Okay, so pay attention to the standard procedures, the rules, and policy that are health and safety related in school and also in the hospital. Okay. I'm not so much familiar with how it is implemented across Indonesia, but for sure there are at the very least standard procedures. So if you are into the habit of studying the standard procedure, you will be able to protect yourself and your patients well. That's a very good, shall we say, principle to go by in your practice. When you protect yourself as a healthcare worker, you actually protect your patient too. We're always taught about patient safety, right? But one pillar of patient safety actually is the safety of the healthcare professional. You cannot take care of your client or your patient if you yourself are not safe. And to make yourself safe, you study well the standard procedure. Okay. It's often challenging to practice in healthcare. You might need to do, for example, modification, but you'll only be able to do your modification confidently if you know what the standard procedure is. Okay, so yeah, study the standard procedure really well, and look for the health and safety practice or procedure that would be present. Okay, wherever you go, if you have that habit, then you will be able to keep being the best practitioner, and you'll keep your patient safe too. Okay.
Thank you, Miss Gayline. I will do my best for that. Thank you.
Perfect. Thank you,
Thank
doctor.
you. Okay. Thank you for your attention and participation. Maybe I would like to highlight some points of this academic session. First, we must consider that occupational health, as also mentioned before earlier, that 60% are workers, but more than 60% actually, because Gayline mentioned that the impact of occupational health also involve the family, the industry or company, and the patient itself. So I think don't focus on the number, but focus that the impact is bigger than we are thinking before. So just like the last question, and focus on protect ourselves, then help others, then just like in the plane. Okay, thank you. So go back to the MC. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Dr. Kita, as the moderator, and Ms. Gayline for the very enlightening presentation. Okay, we would like to give some, maybe not souvenirs, I think it's the certificate for Dr. Kita and for Ms. Gayline. Ms. Gayline for the presentation. It will present on the screen. Okay. Okay. Okay, please applause, give applause. Okay. And for Dr. Kita as the moderator. Okay, thank you. Okay, I think it's the end of the show. It's the end of the event. Thank you for all the audience. I hope you enjoyed the enlightened presentation and the discussion today. Let's close this lecture with doa kafaratul majelis. Subhanakallahumma wa bihamdika asyhadu an la ilaha illa anta astaghfiruka wa atubu ilaik. Thank you and wassalamualaikum warahmatullahi wabarakatuh. Oke, thank you. Untuk adik-adik mohon mengisi kuesioner yang ada di layar dengan scan QR code. Di situ akan ada survei dan kuis. Mohon diisi sebelum meninggalkan ruangan, harap diisi dan disubmit